Good morning, everyone. My name is Dr. Charles Moyo. Welcome once again to the UCT-African academic presentations. Today, I'm going to lead this discussion on a pathology or basically a neurology case that we managed in our ward. This patient was admitted early this month. So this is the outline of my presentation. We'll start with the case discussion, and I will review the literature and take you through an approach to Petrous Apicitis, and I'll try to summarize and give an algorithm of how we can approach these patients. So I've obtained consent to use this patient's clinical information and also for these images to be shared on this platform. No intention for any copyright infringement, and I have quoted my references on my slides as we go through. So without further ado, I will go into the case presentation. This is a 17-year-old male patient, currently still admitted in our ward, presented early this month with a 6-day history of right gaze diplopia associated with talgia and right-sided facial pain with associated retroorbital pain. It's also subjective loss of hearing on the right side with right-sided hemicranial headaches. Some of the important negatives on the history: this was his first episode of such symptoms. He had no chorea, had no neurological symptoms or any signs of any other cranial nerve fallouts. He didn't have any history of any seizures. He didn't have any constitutional symptoms. He had no history of any TB conduct. He didn't have any fever or any prior EA interventions. So of note is that he was newly diagnosed HIV positive on this current admission with a CD4 count of 276 with a viral load of about 99,000 copies. He is also a polysubstance user and smokes about 10 cigarettes a day. So on examination, on general examination, he was afebrile, vitals were essentially normal. On e-examination, it had dull on the right side, it had dull hypomobile TM, it was non-bulging, there was no hyperemia, it was just mildly retracted. With the normal left ear examinations, and clinically there were no signs of any acute mastocytitis. On a central nervous system examination, the T-cells was 15 on 15, no meningism, at right-sided trigeminal nerve fallout, V1, V2, and V3, with right-sided 6 nerve palsy, as you can see on this video of his eye movements. As you can see, there is restricted abduction of the eye movements on the right side. So of note, he didn't have any signs of raised intracranial pressure, and the rest of cranial nerves were essentially preserved. So we went on to obtain an audiological assessment of him. Essentially, he had right-sided mild conductive hearing loss with more or less normal hearing on the left ear. In terms of his blood workup, his full blood count was normal, with normal urea and electrolytes and creatinine. His CRP was borderline raised, it was 18. ESR was raised, the ESR of 62, that which was raised. We subsequently repeated these bloods about 48 hours post admission, and we still maintained a normal full blood count, white cell count, platelets, etc. And the UND also was normal. Other laboratory workup, CSF studies were normal, not suggestive of any bacterial or any viral or TB meningitis. As alluded to by the Adam sign DMS as well, which was less than 2. If it's above 6, in cases where it's above 6, it will be suggestive of TB meningitis. In this case, it was essentially negative. His blood pressure was also negative. So proceeded to obtain imaging. Unfortunately, I didn't include a video. I just included a few slices. So on the to your left, or to our left, is the axial view. That's a post-contrast CT scan, which basically shows that there is this kind of rim enhancing lesion involving the left temporal lobe, and there's opacification of the left petrous apex with bony erosion and kind of sequestration. And on the bony views, as depicted by the blue arrow, you can appreciate that there is opacification and this more or less lytic process in the right petrous apex, and it is non-expansive, and there is opacification of the middle ear space, and also mastoid opacification. And then on coronal and sagittal images, you can as well appreciate this rim enhancing hyperdense collection and the right temporal lobe is associated with the right petrous apex, and also on the sagittal view, you can as well appreciate the same pathology. So at this moment in time, working diagnosis of the Petrous Apicitis with the right pointed to the right temporal lobe axis. So basically, this is the area that we will be focusing on in terms of our discussion. So if we look at management, he's being managed as an inpatient. He was clinically started on intravenous high-dose ceftriaxone. In analgesia, we consulted neurosurgeons and ophthalmologists who confirmed that this patient had kind of, from the ophthalmology or orbital point of view, had isolated right sixth nerve pulse. The rest of the nerves were spared, and he is currently inpatient on neuro observation. So about 3 to 4 days post admission, he was taken by neurosurgical colleagues for a transforaminal bifuroscopic guided taping or aspiration of the abscess. They aspirated plus or minus 2.5 grams of frank pus that was sent for microscopic culture and sensitivity for TB, MCNS, and geniospec, and fungal stains and cultures. So when I also discussed with the neurosurgical colleagues, this usually they use this approach when they want to inject a medication for intractable trigeminal neuralgia. So since this lesion or this collection was kind of closely associated to that area, they decided to approach this in the same manner. So as you can see in this image, this is the fluoroscopic guided technique. Basically, that's the cellar, and this is the clivus area, and you can see the needle as it is guided towards that towards that temporal lobe connection. So this is basically an exemplary diagram just to try and show you how this technique is performed. So basically, they approach this percutaneously, and they set this spinal media about 2 to 2 centimeters lateral to the corner of the mouth. On this kind of annotated diagram, you can appreciate the area where they are targeting, to access the foraminal valley. So basically, they need to introduce about 45 degrees plane of the heart palate, about 20 degrees from this vertical plane. and then a fluoroscopy is used to guide the access to the foramen value. So subsequently, day 1 post transforaminal value checking, I get a repeat CT imaging which shows interval improvement in the size of that enhancing collection is that we can appreciate in this coronal view, and also on the exam view, there was definitely interval improvement in the size of the collection. So in terms of his progress, is about 2 days post-taping is trigeminal nerve fallout completely resolved, but he still has got a persistent right abducens nerve fallout. On the specimens that were sent, unfortunately, on MCNS, there was no growth after 2 days of incubation. TB workup was also negative. Certain stain was negative. Diagnostic was negative. Fungal stains were negative, and actually reviewed his fungal cultures in this morning that were also negative. So essentially, we don't have any back yet, but clinically, his markedly improved. He doesn't have any meningitis, and he's been completely stable. So this brings us to our topic of discussion today, which is Petrous Apicitis. So basically, Petrous Apicitis this is an infection that is caused by medial extension of acute otitis media into a pneumatized Petrous apix. It has been historically thought that it is always kind of a result of direct extension through these pneumatization cell tracts into the Petrous apix, but it's been shown that spread of infection may occur via hematogenous or lymphatic channels. It is a very uncommon due to the widespread use of antibiotics. That's why this is a kind of a rare entity nowadays. And so in literature, most cases are case reports. There are no prospective studies because of the rarity of this condition. However, in literature, it's been noted that it has got a low mortality rate of -5 to 7%. That is according to the systematic review that was published in August this year. Of course, we cannot mention Petrous Apicitis without the mention of this Italian professor, who initially in the early 1900s came up with this classic triad of purulent bacteria, abducens nerve palsy, with trigeminal nerve, which he equated to the classic kind of symptoms of Petrous Apicitis. However, he was challenged later on, and he then revised this to add other features like fever, otalgia, and other cranial nerve deficits into this definition of Petrous Apicitis. And therefore, you should note that Petrous Apicitis is not equal to Prader-Nichols syndrome. For you to kind of diagnose, to make an impression of Prader-Nichols syndrome, you need to have a triad of these symptoms. So you find that about 20% of patients with Petrous Apicitis, they present this classic triad of Prader-Nichols. So even this syndrome is very rare, and it's actually being defined as a forgotten syndrome. So if you look at the clinical presentation of Petrous Apicitis, most patients will present with the recent acute otitis media. They may present mostly conductive hearing loss. In about 20% of the cases, they may present with the Prader-Nichols triad, that is, signal palsy, respiratory, and facial pain. However, these some of the patients present with kind of isolated entities of this Prader-Nichols triad, like in about 50% of patients with Petrous Apicitis, they will present with cranial palsy and about 65% will present with facial pain. and other symptoms and facial weakness or vertigo. If we look at the microbiology, by far the most commonly isolated organism is Pseudomonas in about 35% of cases, followed by Staphylococcus aureus. However, you may also get other organisms like which cause acute otitis media, like Haemophilus influenza, Moraxella catarrhalis, and Streptococcal pneumonia, or other streptococcal species. And you should as well consider atypical infections like TB and atypical mycobacterial infections. And in one case study, they actually isolated a viral infection as a cause. So if we look at imaging, CT scan and MRI, we basically complement each other. So if you look at features of Petrous Apicitis on the CT scan, they could be asymmetries, which could be normal. And you have to look at the air cell opacification and look at the trabecular, if there is trabecular breakdown and kind of formation of a mature collection. And you look at cortical bony erosion rather than expansion, which you would expect in cases of like a mucocele, or if there is a cholesterol granuloma, which are part of your differentials. And then in some of the MRI features of Petrous Apicitis, it is usually low signal T1 and high signal on T2 with rim enhancement post gadolinium contrast infusion. As you can see in this MRI, this is a T1 weighted. So this is a contrasted T1 weighted image with fat suppression, but you can appreciate this high signal kind of contrast enhancement that is more heterogeneous in this area of Petrous apex, with involvement of the internal auditory meatus and clivus area, and also kind of encroaching onto like this area. So if you look at the differential diagnosis, as we know, the Petrous apex is not quite accessible. It's not easily accessible surgically. So most of the cases we rely on imaging, and also fortunately these some of these differentials, they've got characteristic or diagnostic features on imaging. So these are some of the examples of differential diagnosis that you should consider in patient presents with suspected Petrous apex lesions. So on top of the list, which is usually incidental findings, the cholesterol granuloma, that typically is got a high signal on T1 and T2 and does not enhance on with gadolinium contrast. We also should consider cholesteatoma, which is quite common, and which is also low signal on T1 and high on T2, but does not enhance with gadolinium. So if you want to differentiate the cholesteatoma from other Petrous apex lesions, we have to do a diffusion weighted MRI, which will indicate that it's restricted diffusion in case of a cholesteatoma, or in case of a cholesteatoma. And then the other differentials would be mucocele, paragangliomas, which show a salt and pepper appearance and enhancement with contrast with their cousins, that is the meningioma and schwannoma, which also enhance with contrast. So these, I think, are some of the differentials that I've found, some of the MRI features that I've found helpful if you want to differentiate these Petrous apex lesions. So now we can look at this diagnostic algorithm. If you see, if you review in literature, there isn't much consensus in terms of diagnostic approach, or because the fact that the Petrous Apicitis is quite rare. So you see that Kadri and Cole in their retrospective review of this is by far one of the largest retrospective patient series as far as Petrous Apicitis is concerned. That was published in 2018. So they tried to come up with this algorithm that I found also useful in terms of approaching these patients with Petrous Apicitis. So if you've got a patient with suspected Petrous Apicitis, patient presenting with otitis media, with severe deep-seated facial pain or retrofacial pain, with or without focal neurology. So we have got two scenarios where one is that we've got a draining ear where the chain is perforated, or a case where the human membrane is intact, there is no drainage. So this you may need to approach them differently. If there is already drainage, you can obtain a pass swab for bacteriologic cultures. You always have to get an audiogram, high-resolution CT scan with or without an MRI scan, depending on the resource availability. Now, if the patient is getting intact human membrane, you may want to do a meningotomy and put in a format just to obtain cultures if you don't have any other means of obtaining specimens. And then they as well need high-resolution CT scan and an audiogram as the basic and minimum investigations. With or without an MRI scan, if the resources permit. And then on CT scan, if you've got characteristic features like clouding of Petrous apix, or there's breakdown of the trabecular, cortical bone breakdown, with or without dural involvement, and if you obtain an MRI scan with typical features that's isodense on T1 and enhancing on hypertension on T2, with the enhancement of gadolinium, with ring enhancement of gadolinium, that would be suggestive of diagnosis of Petrous Apicitis. And then management basically involves the appropriate culture-directed antibiotic therapy, usually a prolonged course with a minimum of 6 weeks, as you see later on. And then you also have to involve infectious disease colleagues, and surgery is indicated in certain cases, and you make sure you do serial clinical evaluations to pick up complications or early deterioration. Then if you look at the medical management, so empiric broad-spectrum antibiotics should be commenced early. As recent reports actually suggest the use of high-dose broad-spectrum antibiotics with intracranial penetration. So as you saw in our patient, we used a high-dose ceftriaxone, and the minimum duration of therapy should be about 6 weeks, and antibiotics should be changed once we obtain cultures from a microbiological perspective. And then, surgery is indicated in some cases, but you should note that you should consider the adage primum nocere, that is, you do no harm first, and consider the risk-benefit ratio, as we know the complex anatomy of the Petrous apix. But there are essentially two scenarios that one may consider surgical management. The first scenario would be if there is an obvious acute otitis media, where one may need to do a meningotomy and a ventilation tube insertion, and then subsequently obtain samples for microscopic culture and sensitivity. And if the patient has got clinically mastocytitis, you also may need to do a wide cortical mastectomy, and then also obtain samples in the same setting and send them for microscopic culture and sensitivity. In our setting, we always send the specimens for TB as well as histopathology. And then the second scenario is in patients who have failed to improve despite adequate medical therapy. or patients would develop complications. So in these patients, you may want to be more aggressive in your surgical approach. Maybe one can do a mastectomy in the direction of the Petrous apex, basically with the aim to drain the Petrous apex and stop the trapping phenomenon. So in this systematic review that was published here, is noted that approximately about 2/3 of patients require surgical intervention, and these are the various surgical interventions that have been reported in literature, from meningotomy, mastectomy, petrosectomy, transsphenoidal drainage, and craniotomy in a few cases. So I would say if you are to employ a surgical approach, as well depends on various factors. One, the surgical skill of the surgeon, your institutional factors, what you can offer as an institution. And if you look at the patient's factors, it depends on the available air cell pathways. If you look at your temporal bone scan, whether there are available air cell pathways below or above the labyrinth or anterior posterior to the labyrinth. And also depends on the hearing status of the patient, if they have serviceable or non-serviceable hearing. And it depends as well on the on the portion of the Petrous apex involved, whether is it more anterior or more posterior Petrous apex around the internal terminatus area. So I won't discuss these approaches in detail. It's a completely topic of discussion on its own. But I'll just highlight, how the main kind of approach is the Petrous apex with these different approaches. So I'll divided the surgical approaches into the posterior, approach to the posterior part of the Petrous apex, and approaches to the anterior part of the Petrous apex, and then subclassified these approaches into the hearing preservation and the non-hearing preservation, which is of course the translate approach. So if you look at the posterior Petrous apex, these are some of the approaches that one can employ, but you should notice that in most of these cases, you have to look at your temporal bone scans and your anatomy in order to decide which one would be the best approach. So one can do an inferior approach, but check note if you've got a high right ventricular valve or very sclerotic mastoid, where this could be quite challenging. A retrolateral approach, or what they call is a sinusoidal angle approach. As you can see, if you've got a very anterior sigmoid, that could be nearly, impossible to pursue. So you take into consideration these approaches based on the anatomy of the temporal bone of the patient. And then you can also employ the sub-apate approach, but this can be challenging in cases of very low lying technique as well. So this basically, the image you right, this basically shows, the axis with the translational approach, which usually gives a very wide access to the Petrous apex, if you want to access the internal terminators. And then this one shows, how you access retrolateral via the sinusoidal angle approach. As I have alluded previously, you can see that if your segment is quite anterior, in cases of a high right ventricular valve, this can be quite challenging, nearly impossible to pursue. And then if you look at the approaches to the anterior Petrous apex, you can either approach this by an extended intracranial fossa approach, or an infracochlear approach, but always take into consideration the anatomy and the cell tracts that are that are available. You can actually also approach these anterior petrous apex via infratemporal approach, fish type A and B, or a transphenoidal or transphenoidal endoscopic approach if the carotid, the petrous portion of the carotid is not in the way. Or one can also employ the glenoid fossa approach, where you displace this contents of the glenoid fossa anteriorly to approach this anterior petrous apex. And of course, the non-hearing preservation, approaches, that is your transcochlear or transotic approach. So if you look at monitoring treatment, there is in literature there is no consensus on which tools to use in terms of treatment monitoring. As it was been noted that actually disappearance of symptoms is not even sufficient to discontinue antibiotic therapy. So in literature, there is no detailed criteria for stopping antibiotics, and there's no consensus on which tools to use to monitor treatment or to come up with the criteria of stopping medical treatment. CT scan and MRI scan, they are pitfalls due to the fact that they've been noted that they are persistent, they may be persistent abnormalities, despite the patient being asymptomatic, making those two entities also unreliable as a tool to guide a discontinuation of therapy. Recently, there's been a proposal of a gallium uptake scan due to the fact that these gallium scans have been used to monitor treatment in patients with scalp-based osteomyelitis. But however, this has not been investigated or studies in terms of use in patients with Petrous Apicitis. But otherwise, normalization of findings is on a gallium scan is a good indicator of healing, as gallium is uptaken by inflammatory cells. And on that note, a positive finding that if there is uptake, that precludes stopping medical therapy, because it shows that there is ongoing inflammatory process. So, is to kind of summarize the management again, in this article they came up with this management algorithm, but you should note that you should always tailor management in terms of your resource availability, skill set of the surgeon, and also, the patient factors that I've alluded to previously. But basically, I think this is a very useful algorithm that after you've diagnosed the patient with Petrous Apicitis, this is a kind of a minimum blood workup that you need, a full blood count and inflammatory markers, your CRP, and you commence the patient on empiric intravenous antibiotics with intracranial penetration, and then you change these antibiotics based on cultures, and consult your neurosurgical colleagues and infectious diseases colleagues. And there are two scenarios: either the patient improves clinically, or there is worsening within 24 to 48 hours. If there is worsening of symptoms, these are the patients that you need to consider surgical management, where your access should be based upon the least morbid and shortest approach, in view of your imaging. And then if there is a clinical improvement, we need to keep these patients on antibiotics for a minimum of 6 weeks and modify therapy based on cultures and subsequent imaging. And if the patient initially improves and there is clinical worsening, this depends if there is either rapid worsening, and if there's rapid deterioration, you need to consider surgical, surgical intervention. But if there is kind of a slow worsening of symptoms, then these are patients that you may need to modify therapy based on your cultures, or follow up with repeat imaging, with the primary goal of resolution of disease. So in summary, Petrous Apicitis, it is a rare condition, but potentially life-threatening. And we should note that the incidence of cardiac child in Petrous Apicitis is quite low, and you should have a high suspicion and a low threshold for imaging and surgical intervention in these patients to prevent morbidities. And management involves a prolonged course of broad-spectrum appropriate antibiotic therapy and surgery where indicated. Thank you. So, yeah, at this moment, I would invite any questions and contributions and comments.
That's a very nice presentation, Charles. Just a few comments. You know, in this article's diagnostic algorithm, you looked. They mentioned MRI scan as well. Is that right?
Yeah.
So I think for me, there's no indication to do an MRI in this case because it's fairly clear cut. You're looking at a CT with this mastoid opacification, Petrous apex opacification with erosion. And those, the MRI I usually use where there's an isolated Petrous apex lesion that one cannot access, and therefore you cannot make a diagnosis unless you have CT and MRI. I'm really worried about these patients because there are very few things that actually look like that. So the rest of the mastoid is opacified with Petrous apex opacification and bone erosion. It must be something infectious. It cannot be anything else. I think it's a waste of a resource to go and ask for an MRI scan. Yeah. The second thing is, I think you have to differentiate between Petrous apicitis with mastoiditis versus Petrous apicitis. So in this case particularly, you palpated the mastoid, there was absolutely no tenderness, there was no erythema. And I think those two patients have to, those patients, you mentioned the clinical presentation basically. So if they have mastoiditis or Petrous apicitis with no intracranial collection, I would start an IV antibiotics. You can do a barometer, there's a bulging TM, you can take a swab, but if there's no improvement after 24 to 48 hours, then I would do a mastoidectomy there because this patient has mastoiditis as well and needs to be managed like mastoiditis. If there was a Petrous apicitis with an intracranial collection, I would also be very cautious about, so that this patient was different, right? This is not just the Petrous apicitis, where there's a place for conservative management of high-dose IV antibiotics. There's no intracranial collection, you can go that route. But where there is an intracranial collection and you want an organism, and then you have to look very carefully at your scan and go, well, can I, because this patient also had normal hearing. And I think they, what I would do, you're not going to go and do a full drill out, but at least do a mastoidectomy and myringotomy, take a pus from that mastoid and hope that Petrous apex will drain via the mastoid. Because you have a collection. So, for example, you would manage a frontal sinusitis with an intracranial collection and go, let's manage with IV antibiotics. You're always going to do a trephine, aren't you? And this is pretty much, I would think of it in the same way because the morbidity is quite, and mortality is quite high. So the room for conservative management here is really Petrous apicitis without a collection and without mass, those patients you can manage. Be very careful about your diabetic patients. So your diabetic patients, you can get Pseudomonas. And obviously HIV positive patients, you can get funny organisms as well. And I mean, we really see this, maybe 1 every 2 years or so, and in an RCT TB. But the TB patients that I've seen with that present with Petrous apicitis, they don't have that deep-seated notalgia. They present very differently. So they have the oturia, they may have a 6 palsy, they may even have a 7, but they don't have that deep-seated notalgia. I mean, I may be wrong. This is just going anecdotally. I've really seen, but they've got that bone erosion. So those patients, you want to make sure you want to exclude TB, and especially in the immunocompromised patient. But we tend to be, so from the start, in terms of your imaging, even the follow-up, I wouldn't do a gadolinium scan. It's not going to add anything to your management. You know, you're going to manage this patient clinically. We know what the management is, IV antibiotics. If this patient is not improving on your antibiotics, it's either it's another organism, or you're going to have to go and draw that mastoid out and see if you can, you know, but it's very rare for them not to respond if you're on the right antibiotic and you've got the right diagnosis. They usually respond quite quickly. Yeah.
So question from Zubair. Hi, Zubair. Unmute him.
Zubair, can go ahead.
He needs to unmute himself.
Are they unmuted?
Right. Oh, okay. Can you hear me now?
We can, Zubair. Yes, please.
Hi. Morning. A few interesting thoughts come to mind. I always remember, Prof, one of the cases you spoke about, you often used to speak to us about this lawyer with the cholesterol granuloma that you drained transcanal. I don't know if you remember.
Yes.
I do. Yeah, don't remind me. Yes.
Anyway, so yeah, so this often in private practice, we often see these patients often get referred to us after they from an incidental finding on an MRI, and many of them are not as symptomatic as in terms of patients with very significant infectious disease. So, like for example, there was a patient I had last week with the suspected endolymphatic sac tumor, but that was the differential diagnosis from the radiologist. But so it is sometimes these patients get picked up on MRIs. But the other thing I wanted to mention in terms of the management is there's also the transcanal approach, which so I think from what I heard is most of the approaches you discussed were transmastoid. And so now there is also the transcanal, and obviously if you're using the transcanal, then you can use the endoscopic route. So there's a infracochlear canal sort of that you can identify on some patients, which you can follow. But there's a lot in the literature describing the transcanal. So you go in between the carotid and the jugular, and underneath the cochlea, and you can access the Petrous apex pretty easily. So that's another route to consider as well.
Just on the transcanal, unless that Petrous apex cholesterol granuloma is really at the face of that, sort of below the cochlea, and there's a thin bit of bone, I certainly wouldn't go through a long bony tunnel. You've got a 2 millimeter window between the carotid and the jugular, and I wouldn't go and blindly put a burr through that tunnel because you don't know what you're going to hit. And so that's why I'm going on radiologically what you can see in a scan in terms of what you can access.
I don't think
yeah.
2 millimeter as you go closer, higher up. I don't think it's always 2 millimeter. But obviously, you would follow your imaging and look for the best approach, which is the safest.
The point is, you have to make sure that that Petrous apex lesion is accessible by that. I wouldn't go through a long bony window. That's what I'm saying.
I mean, that's
because
quite obvious.
You're drilling blindly in a tunnel, and I think that's really dangerous.
I think all
I think it's a bit like tumors in the peripheral space. I think the biggest challenge is always planning your approach, and that's going to be on the anatomy and the imaging. Am I right?
Yeah.
And once you plan it, then it's often not that complex. But I think it's choosing the right approach.
Yeah, absolutely.
The issue.
Yeah, absolutely.
That's right.
I mean, I've done most of the Petrous apex cholesterol granulomas. I've done transcanal infracochlear. But I literally look at the scan, Darlene and I, and we go, is it better to do transsphenoidal, or is it better for me to access it? And I've got my other mastoid if it's more accessible, but you literally have to look at the scan and go, what is more accessible? And also obviously taking into account the risks. And I'm very cautious where I have to drill, and so Darlene, where I have to drill through a fair amount of bone. You can't use neuronavigation, because neuronavigation is out by 2 mils. And so it doesn't help you at all. And I think it's fine. If you're lucky, you're lucky. Great for you. But I wouldn't want to hit it. If you hit the jug, you can pack it. But if you hit the carotid, that's not so great.
I'm not saying that's the only way. I'm just saying that.
The point is very well taken, Jabir. Yeah.
Okay, thanks, man.
Thank you.
I don't know if Byron wanna comment on the neurosurgical perspective or approach. I really touched on it, but yeah, it was not quite.
Good morning, everybody. Nothing really to comment. The technique that we use, it's named after a guy called Hartel's technique. And as you mentioned, it's often a route we take for trigeminal neuralgias, so glycerol rhizolysis, and effectively then, basically trigeminal neuralgia, V2, V3 distribution, we inject glycerol, and it works very well for those. Apparently the Prof Lefevre and Prof Taylor have used this approach before for, I think, biopsying a lesion. I had my doubts, but it worked extremely well. And it was a relatively quick procedure. Nothing really needs to add.
Can I just say, we're very grateful that you could access this, because the problem was this access was completely not accessible from an ENT point of view. And none of the cells from biomass would actually drain, that were accessible to the Petrous Apicitis. So access was a big issue. And, even going sort of middle fossa, it's literally in the middle of the skull. So it would have required a lot of brain retraction. So we're very grateful that you could access via the route that you did, because that was basically his only option. But if that wasn't an option in a hospital, I mean, how would you manage this patient? That's the thing. Because not everybody has this. Not everybody has this available. What would your options be, and how would you access it? Because you're not going to go and do middle fossa and retract that brain. I think the only thing I would do here is actually do a full drill out and do a mastoid, and hope that you would have some sort of source control and long-term IV antibiotics. But otherwise, this was completely inaccessible from an ENT side. Would have been very difficult without compromising this patient's hearing. So we can access it, but his hearing would be compromised.
Yeah, I mean, even from our side, as you mentioned, I mean, an open approach would have been extremely aggressive. I mean, it has to come subtemporal. It's not an easy place to get to. And once you do get there, carotids on the other side, cavernous sinuses right there. I think it would have been an extremely difficult approach to open sort of subtemporal and try to drain it openly. So that's why initially when I saw the images, I sent them straight to Prof Taylor, and he had the idea to just stick a needle into it. I agree with you. I think it would be extremely difficult to manage any other way.
Just for those who don't know the technique, do you simply need regular screening X-rays for this, or how do you do it?
Yeah, so we did it in the cath lab. And it's preferable to have a biplane system, but it's not entirely necessary. So 2 screening sort of gantries, and basically, you get your angles right to come over with the fluoroscopy to about 30 degrees from the lateral, and then I think one of the harder parts is trying to find the foramen, and once you've seen it, you then introduce a needle, as Charles said, 2.5 centimeters from the corner of the mouth, and then you sort of take a bullseye approach with constantly screening. So this does expose the surgeon to a fair amount of radiation, and you try and then wear lead-lined gloves while doing it. And then you put your fingers into the mouth so you don't feel that you're going to breach through the mucosa of the mouth. And if you do, then new needle, new trajectory, new insertion. And then basically just walk the needle into that canal. You ideally want to get into the middle half, or the medial half of the foramen ovale. Well, I mean, that's for when we do the cholesterol injections. And yeah, I mean, obviously there's not very far away right behind foramen are sort of the carotid canals and stuff like that. So yeah, I think Prof Lefevre did it. I mean, he's done a lot. They do a lot in private as well. But I think it does take a little bit of a learning curve to get right. Yeah. Yeah, but
that's fine. That's great.
yeah, no worries.
Okay.
Yasmita, in Kenya, have you seen many of these cases? Yasmita Patel.
Yasmita Patel.
Yes. Well, thank you very much. It was a really good presentation. And thanks, Byron, for joining us. I appreciate it.
Shane, thank you very much, everybody.
Yeah, I don't see any further questions. Thank you very much, everyone, for joining for this meeting. We have a pleasant day ahead, and then we meet again next. There's no meeting on Friday, so we meet again next week on Wednesday. Thank you.